Good afternoon, ladies and gentlemen, and thanks for joining us for part 2 of the second session of our 3-part webinar series on Advancing Diagnostics, Evolution in Hematopathology. This webinar series is being brought to you by Unipath Speciality Laboratory and Vanguard Diagnostics, a company engaged in the R&D and manufacturing of in vitro diagnostics products. My name is Veena Kohli. I'm the CEO and founder of Vanguard Diagnostics, and it's my pleasure to welcome each one of you to the second part of the webinar focusing on peripheral blood smear. Today's session will be moderated by Dr. Ravi Gaur. Dr. Gaur is the chairman of the Medical Advisory Committee at Unipath Speciality Laboratory, and he's the founder of DRG Laboratories. Dr. Gaur is a renowned and respected oncopathologist with extensive experience in pathology, molecular diagnostics, genomics, and immunology. He's deeply committed to advancing diagnostics towards personalized medicine and emerging technologies. Ladies and gentlemen, we are extremely privileged to get another opportunity today to learn about the structure, function, and pathology of white blood cells and platelets from the guru of hematology himself, Dr. Tejendra Singh. Dr. Singh brings with him over 40 years of diagnostic experience and wisdom. Dr. Singh's contributions to the medical education in India have been tremendous and significant. He has shaped the understanding of this field for many generations of students. So let's immerse ourselves into this fascinating topic of peripheral blood as our experts share their insights. So it's over to you, Dr. Gaur.
Good afternoon, everyone, and good afternoon, Veena ji, and good afternoon, sir. It's my pleasure to be here with all of you for presenting again this scientific seminar series. And thank you, firstly, let me say, Veena ji, for organizing this amazing scientific series. And I think the idea of what we started sometime when we had first series on taming the typhoid, which was probably related to the, how to get the biggest problem today. We still have the diagnostic challenge with the typhoid, and probably the PCR kit, which was launched, the taming of the typhoid, probably is helping a lot of people, I'm very sure, to getting a rapid diagnosis and a faster diagnosis and more correct diagnosis, which otherwise takes some time, weeks and 10 days, even 2 weeks to diagnose the typhoid. So probably something that's one good series we have. Again, with the hematology series, which is again thought process of yours, highly innovative, because how pathology evolved, progressive, therapeutic, peripheral blood, coagulation going forward. I think this is a good series. We are probably having a very good response, and I think a need of the hour. And I must say that because I'm very impressed because you innovative thought. Probably now, talking about, you can say the direct to the customer approach of the logistics and the region. That's a wonderful kind of innovation. I'm very sure all of us probably gain from your insights and the involvement. And of course, the scientific series will help us to take our pathology much, much forward. So with that, thank you so much. And I think let me, come back to the series today. Good afternoon, everyone. Welcome to the second of our webinar series, second part, that's the peripheral blood demystified. This session will unveil the mysteries beyond red blood cells. The first session we had RBCs, and I'm Dr. Ravi Gaur, and it is my distinct honor and pleasure to serve as your moderator for this session. In our blood, there is a world unseen. So many of mysteries of life lie in between. Beyond the red blood cells, many other cells are abound. A symphony of life is found. That's how we start with when we talk about the peripheral blood. The human body is a marvel of intricate designs, with each component playing a very, very important role in maintaining overall health and functionality. But red blood cells, RBCs we call, often take the center stage in discussion about blood. There's a rich information beyond this, revealing a world where white blood cells, or WBCs, or leukocytes, what we call them, platelets, and more, each contributes uniquely to our well-being. And in this series, or this session, we'll journey beyond RBCs, uncovering the secrets hidden within the cellular landscape of the peripheral blood. WBCs, or the leukocytes, are the guardians of our immune system. They're patrolling across the bloodstream to identify and combat the foreign invaders. So through the peripheral blood smear examination, we get, as I understand, we gain insights into the composition of the functionality of these diverse cells, neutrophils, eosinophils, basophils, lymphocytes, monocytes. Each have distinct roles in immune defense with abnormalities in their count. Morphology often serving as an indicator of underlying health issues. Now, platelets, tiny yet mighty. I think that's something, despite their diminutive size, platelets wield immense power, forming aggregates at sites of vascular injury and initiating the clotting cascade. Peripheral blood examination allows us to assess platelet count, size, morphology, providing valuable insights into patient risk, bleeding, or traumatic disorders. Now, today we are privileged to have and learn from respected Dr. Tendra Singh, sir, who has significantly shaped the field of hematology with profound knowledge and unparalleled expertise. I don't think anybody needs an introduction, sir. I think it's an honor to have you here. Thank you so much for being with us and sparing your time. In any case, I think anywhere when we talk about hematopathology or pathology or institution, I think sir has been like a mentor, guide for all of us, and he has been heading bodies of all possible pathology bodies and written so many books and publications. Thank you, sir, for being with us and mentoring us. Sir I think, is not only a mentor to many, but also a symbol of humility and dedication to the diagnostic community. His contribution have enlightened countless students, and I am one of his students, and been privileged and proud to say that. I've been very, very highly, big learning, and still I work very closely with him. There's always any problems of beyond profession also. I think he's something who guides me to the right direction. Thank you, sir. Your commitment to education is truly inspiring. It's often said, that's a personal thing I know what I want to say before we start the session, that true measure of teacher is not in their accolades, but in the lives they touch and knowledge they impart. Sir embodies the principle with grace and humility. His ability to simplify complex concepts and his unwavering support for his students makes him a revered figure in our field. Without further delay, please join me in welcoming our esteemed mentor and respected sir as he takes us our journey to demystify peripheral blood smear examination. Sir, please take it over.
Thank you, Dr. Gaur. Thank you, Dr. Veena Kohli. It is always a pleasure to be associated with Dr. Gaur and Dr. Kohli. And if you remember, last time we had spoken about the peripheral blood film. And at that point of time, we had talked mainly about the red cells, the mainly anemias. But we know that the blood contains white cells and platelets, which play a probably more important role in combating the infections and controlling the bleeding. So today I'm going to talk about the morphologic changes which can detect the disease with different diseases in blood, both white cells as well as platelets. All right, is my screen visible and am I audible?
Yes, sir. Yes, sir.
Okay, fine. Now, last time I showed you this slide that what we are going to talk about is about the red cell morphology, then WBC morphology, platelet morphology, then the hemoparasites, which we detect in the peripheral smears, and artifacts and troubleshooting. So out of this, we have spoken about the first two aspects, that is the general examination of a smear and the red cell morphology. So today we start with the WBC morphology. See, this is a peripheral smear, and what we are going to talk about today is the neutrophils. We are going to talk about the lymphocytes, eosinophils, monocytes, and of course the platelets not seen in this picture. And of course, red cells we have already spoken about. See, peripheral smear is not only a hematological tool for screening, but also for diagnosis and also for monitoring of disease. That is the progression of the disease. And then once we give the therapy to see the response. See, there's a case of infection with a count of 14,000 TLC, 90% neutrophils. We give antibiotics to treat the disease. And then we keep on watching clinically as well as what is the therapeutic response. Are the neutrophils coming down? Is the TLC coming down or not? So a simple peripheral smear gives us an idea. Now, there has been hematology automation. There is no doubt. There have been more and more molecular techniques coming every day. Every day now the classification is being changed. First by WHO, and then we have the ICC group, which is changing the classifications. The hematology automation has played a great role in advancing the knowledge about blood. But the fact remains that the information provided by peripheral blood film is tremendous and is unmatched. Now, which part of the smear should we examine? We had last time talked about that we should not do the differential count in the tail of the smear. So what do we find here at the tail of the smear? At the tail of the smear, you can see mainly the neutrophils and you can see the monocytes and the larger cells. All the larger cells in the smear are, as we make the smear, those come to the tail. Then if we want to study about the cytopenias or cytophilias, like leukopenia or neutropenia or lymphocytosis, we should not go to the tail. We have to examine the tail to look for if there is tailing in the smear. And then any morphological abnormalities. And another thing we have to look for is there any abnormal cell present in these cells or in the smear? Say, for example, here what we find in this particular smear, you can see 1, 2, 3, 4, 5, 6 nucleated RBCs are there, and the white cells are diminished. The red cell is showing a Howell-Jolly body. Now, if we find nucleated RBCs, then how do we do the TLC? So what we do is we always apply a correction. When do we apply the correction? When the nucleated RBCs are more than 10 per 100 WBCs. So we express the number of nucleated RBCs as, say, 5 per 100 WBCs. We count the WBCs and also keep on counting the nucleated RBC. And then we apply this formula of uncorrected WBC multiplied by 100, and then the number of nucleated RBCs plus 100, and that gives us a formula for calculation of the exact TLC, or what we call as corrected TLC. Then we keep on using the term left shift. Now, what is the meaning of the left shift? Left shift is that these are the neutrophils which are present in the peripheral smear. And then what we find is that there are myelocytes, promyelocytes are also present in this particular peripheral smear. If we find metamyelocytes, myelocytes, promyelocytes in the same smear, we say there is a left shift present, or left shift indicates the presence of these immature cells in the peripheral smear. Similarly, look at this peripheral smear. What we find is this is a band form. Now, band form is also an immature neutrophil. It is not a mature neutrophil, and a myelocytes. So their presence indicates a left shift. Not only that, we use the term leukemoid reaction. In a leukemoid reaction, we find there is leukocytosis, that is number one. And number two is the presence of metamyelocytes, myelocytes, promyelocytes, and the band forms. Then we use the term leukemoid reaction. And it is an indication of bacterial infection. Now, what about the band neutrophils? As you can see, a band neutrophil over here. This is a very, very important sign if you look into the peripheral smear carefully, especially in children, more so in neonates, because if we find more than 15% of band neutrophils, it indicates poor prognosis. So now what does it mean? Band forms is an indication that the child has got a bacterial infection. Now, usually in children, pediatricians are very, very careful. They don't give any antibiotics unless there is a bacterial infection. For viral infection, no antibiotic is given. So here the presence of these band form more than 10% indicates that the child has got infection. Now, which infections usually? See, we know that in children, diarrheas are very, very common. Viral diarrheas due to rotavirus are very common. Of course, the bacterial diarrheas are also seen. But the pediatrician will give antibiotics only if there is a bacterial diarrhea. So what are we looking in the peripheral smear in that small child is bandemia. If you find good number of band cells, that means it is a bacterial infection, then the clinician gives the child antibiotics. Now, what about the abnormalities in the neutrophils? There are changes in the nucleus. What changes can occur in the nucleus is Pelger-Hui anomaly. Now, which can be seen in is a hereditary condition, or it could be a myelodysplastic syndrome, or a pseudo-Pelger-Hui anomaly. Now, what is this Pelger-Hui anomaly? I think the picture you are not able to see. So, all right, this is the Pelger-Hui anomaly. Now, where we find that the nucleus is spectacle shaped and it is joined by a thin chromatin bar. Now, this is an inherited condition. And what is happening here is hyposegmentation of the nucleus. You are not finding the usual 3 to 4 or 5 lobes of the nuclear chromatin. You are finding spectacle shaped nucleus. So they resemble, the neutrophils resemble bands or metamyelocytes. Now, these are the Pelger-Hui cells. Now, what happens is that sometimes the clinicians take them for band forms of neutrophils, and then there is a problem because these are present in certain hereditary conditions like Pelger-Hui anomaly. So it should not be taken as equivalent of band forms of neutrophils. And if we find them in an adult, especially old people, pseudo-Pelger-Hui anomaly, similar cells I'll show you. And what you find is that these are the features of myelodysplastic syndrome. In a peripheral smear, if we find pseudo-Pelger-Hui cells, we find the metamyelocytes. And what is happening is that the chromatin pattern of pseudo-Pelger-Hui anomaly granulocytes, you find that it appears mature and coarse nuclear chromatin. And then the cytoplasm is devoid of toxic changes. That means the toxic granules are not seen over there. Now, these are all pseudo-Pelger-Hui anomaly where you find coarse chromatin, condensed chromatin joined by thin bar. Here you find that there is no division of the nuclear chromatin at all. It is something like what they call as peanut type of the nucleus is seen. But then this is a pseudo-Pelger-Hui anomaly. This is an acquired one. And here you will come across the toxic granules will also be seen. These are all pseudo-Pelger-Hui anomaly cells. And we may come across unilobed form or we may come across bilobed forms. So which are the causes of pseudo-Pelger-Hui anomaly? MDS is one, AML, CML, and myelofibrosis. These are 4 main causes in which we find pseudo-Pelger-Hui anomaly. Then transient benign causes. That means these are present, such cells are present for a short time, like in infections like HIV, tuberculosis, mycoplasma pneumonia. Drug intake of cotrimoxazole, colchicine, sulfonamides, ganciclovir, and valproate. Immunosuppressants like azathioprine and mycophenolate, and transplant medications like tacrolimus and prednisolone. Now, these are the immature granulocytes which you come across sometimes in a leukemoid reaction. Now, this is not leukemoid reaction, but this is a case in the peripheral blood. We are looking at peripheral smear of a patient of chronic myeloid leukemia. In chronic myeloid leukemia, we come across few blast cells. As you can make out, 2 to 3% blast cells are present. You are seeing the promyelocytes, myelocytes. You are looking at metamyelocytes. You will come across occasional basophil also. There is basophilia, eosinophilia. Now, immature granulocytes could be seen in bandemia, as I told you earlier. Then in certain conditions like myeloproliferative disorder, which is like a CML, but we can come across in polycythemia vera also. Surgery, post-surgery and post-hemorrhage, we find that there is a reaction by the body, and this is a reaction in which we find that the immature white cells come into the peripheral blood, and these are seen in the smear. Then immature granulocytes are also seen in these benign conditions, as well as in myeloproliferative, myelodysplastic disorders. Then we have to differentiate what we are dealing with. Is it a leukemoid reaction? Is it a case of CML, or is it a chronic neutrophilic leukemia? In chronic neutrophilic leukemia, which is a very uncommon type of chronic leukemia, we find that the neutrophil count is usually more than 90% and is associated with CSF3R mutation. Lab score, or the leukocyte alkaline phosphatase, is very high. Now, lab score is very low in cases of chronic myeloid leukemia. On the other hand, in neutrophilic leukemia reaction, the lab score is very high. So earlier we used to do lab score on neutrophil alkaline phosphatase score. If it is more than 100, we would go for neutrophilic leukemia reaction or chronic neutrophilic leukemia. And all CML cases would show a very, very low NAT score unless the patient is going into a blastic phase of CML. Then, of course, we all know that in CML, you come across Philadelphia chromosome or BCR-ABL, which is not seen in neutrophilic leukemia reaction, being a benign condition. One condition we have to keep in mind is that G-CSF therapy or Neupogen. Now, G-CSF therapy is nowadays given to many patients with various malignancies. See, a case of breast carcinoma, surgery is done. Followed by surgery, there is a radiotherapy. As you give radiotherapy, you give chemotherapy, what happens is that there is a neutropenia. Now, as a neutropenia occurs, to stimulate the bone marrow, the clinician gives granulocytes colony stimulating factor, or GCSF. Now, what does that cause? It causes rapid proliferation of the myeloid cells in the bone marrow. As you can see here, it is so rapid proliferation that majority of the cells you are seeing are promyelocytes. There is no time for them to even mature. So in a case of GCSF therapy, in the peripheral blood, we find metamyelocytes, myelocytes, few promyelocytes. Rarely blast cell is seen. But in the bone marrow, you will find there is a maturation arrest, which occurs usually at the promyelocyte stage as it has occurred. So this possibility, you should always ask from the clinician if the patient is on GCSF therapy. On the other hand, if we give MCSF or monocyte colony stimulating factor, there is some degree of monocytosis which is manifested in the peripheral blood. Then in neutrophils, we should be able to appreciate these coarse granules. All neutrophils have very fine granules, but you have to look for them in oil immersion. In oil immersion, you should examine the cells in which you can look for the granules. And here you find there are coarse granules. Now, these are the toxic granules. So any infection which is occurring in a child or an adult, bacterial infection leads to toxic granules in the neutrophils. The presence of toxic granules indicates bacterial infection. So you start the treatment accordingly. Then sometimes you find that the person has got a bacterial infection. Look at in oil immersion and you find there are fine vacuoles in the neutrophils, again bacterial infection. But in both these conditions, whether toxic granules or vacuoles due to bacterial infection, you find that the NAP score is high. Now these blue colored granules are in the neutrophils and the score is more than 100. The normal NAP score is 40 to 100. And of course, in CML, as I told you, that you will come across promyelocytes, myelocytes, occasional blast cell also in the peripheral smear. Not only that, we come across neutrophil inclusions like Dole bodies, as you can see the blue dot which are being seen in the cytoplasm. Now, Dole bodies are again seen in cases of bacterial infection. So rarely we come across there are yellow granules or big blobs. These are the bilirubin crystals which we come across in cases of jaundice. Now, this is a case where we found that there were big granules in the neutrophils, not only in the neutrophils, as we looked in the lymphocyte, they were present in the lymphocyte, also present in the monocytes and eosinophils also. So all the granules were very, very large. Now, such granules are seen in Shidaki-Higashi syndrome, now in which we find that the immune status is low, there is increased susceptibility to infection. Not only that, these children have got cutaneous and ocular albinism. So if once you have seen such coarse granules, which are dark brown in color, one can easily pick up cases of Shidaki-Higashi syndrome. Then we find that these vacuoles in the neutrophils are not only seen in bacterial infection, but in certain lipid storage diseases also. And you will come across these vacuoles in the cytoplasm in the neutrophils and also in Shannerin-Dorfman syndrome. Then in cases of toxic granules, it is almost certain that we are dealing with a case of bacterial infection, unless it is a case of chronic neutrophilic leukemia. In chronic neutrophilic leukemia also, you will come across granules which are similar to toxic granules. So we have to see to it that it fits in with the criteria of WHO before we diagnose a case as chronic neutrophilic leukemia. Now, we all know that how do we diagnose cases of myelodysplastic syndrome. Now, myelodysplastic syndrome is not an uncommon syndrome, and the diagnosis is usually made first on the peripheral smear, or a suspicion arises on the peripheral smear. Then we do a bone marrow, confirm the findings, what we are seeing in the peripheral blood, and then we go on to cytogenetics and molecular tests to confirm that this is a case of myelodysplastic syndrome. Only then we can start the therapy. So what all changes we come across in a case of MDS is, number one, in the neutrophils, what you are looking at, the two neutrophils, they are showing no granules at all. The cytoplasm is devoid of granules. So this is hypogranulation. Then we find nuclear sticks. Now here you find there is a ring neutrophil, and in the ring neutrophil again, you find this abnormality that the chromatin bar is coming from one part of the circle or the nucleus ring to the other one. This is again a ring neutrophil which is seen in myelodysplastic syndrome. Then we find that the chromatin is not the usual one, it is rather more coarse, and it is an abnormal shape of the neutrophil. Of course, the hypersegmented neutrophils are seen in cases of megaloblastic anemia, we all know. But if you find that too to be abnormal, these are all features of dysmyelopoiesis. That is the term we use for neutrophils which are seen in these cases. Now, as far as OR rods are concerned, we know that the OR rods is a feature of AML, especially cases of M2 and M3, where we find multiple OR rods in cases of M3. But then in cases of MDS, we may come across OR rods in the neutrophil, in the metamyelocyte, in the myelocyte, because it is an abnormal thing and the dysplasia is to a high degree. So you will come across these OR rods in the neutrophils, metamyelocyte, and myelocyte. Now, dysmyelopoiesis is manifested in the bone marrow as well as in the peripheral blood. Now, what do we find here? You will come across, here you find again a ring neutrophil, and then you are finding these abnormal white cells. The neutrophils are abnormal, their shape is abnormal, and then there are two neutrophils at the back which are again showing abnormality. So there is also you find loss of granules. See this neutrophil at the edge, you find there is loss of both primary and secondary granules. Or sometimes we come across giant granules. Then you find that the shape of the metamyelocytes, shape of the band forms is abnormal. This is not the usual normal shape, but we are finding here lobation is also occurring, which is not a feature of a normal neutrophil. So all these are features of dysmyelopoiesis. So unless you see such abnormal white cells on a peripheral smear, we don't think on the terms that the patient is suffering from myelodysplastic syndrome. But the moment you find hypogranulation, abnormal granulation, ring neutrophils, abnormal shapes of the metamyelocytes, the band forms, and the neutrophils, along with dyserythropoiesis in some cases where there is a multilineage dysplasia. So all these features indicate that the patient is suffering from myelodysplastic syndrome. Now, neutropenia is another thing which we come across clinically, and severe congenital neutropenia is a known condition. Similarly, we find neutropenia in Shidaki-Higashi syndrome as well as in Schwackman-Diamond syndrome. Cyclic neutropenia, we don't know the cause, but it is sort of an hereditary condition in which we find that for 21 days, the patient has normal TLC. And then we find for next 4 or 5 days, you find that the neutrophils are decreased. So this is cyclic neutropenia. Then in autoimmune disorders like Felty syndrome, rheumatoid arthritis, Sjogren's syndrome, you come across there is a neutropenia. One of the main culprits of neutropenia are drugs, whether these are sulfur drugs, azathioprine, chemotherapy, rituximab, benzene, insecticides. All these drugs and chemicals induce neutropenia. Where do they affect? They directly affect either the stem cell or the blast cell, or they affect the, the myeloid series of cells. Infections. Now, which infections will lead to neutropenia? We all know that a bacterial infection like typhoid will also induce neutropenia. Then hematologic disorders like aplastic anemia. Now, we all know that aplastic anemia is a stem cell disorder in which there is paucity of myeloid cells, lymphoid cells. Also, we come across there is a loss of red cells and the platelets. So the patients usually present with pancytopenia. Then we have MDS, where you find pancytopenia. Hairy cell leukemia, again pancytopenia is seen. In nutritional, megaloblastic anemia is very, very important, and it is so common in our country, more so because of the B12 deficiency. Earlier, we thought that it is a folic acid deficiency, but now we know that as all of us are becoming vegetarians, and as a result of which many of us are developing vitamin B12 deficiency, resulting in not only anemia, but pancytopenia. So the causes of neutropenia are classified as drug-induced, and this is the biggest group, and it includes antibacterial antibiotics like chloramphenicol, penicillin, doxycycline, ciproflox, gentamicin, anti-inflammatory drugs like phenylbutazone. It was a very popular drug at one time, but now it is no longer in use. Even diclofenac, now we find that it also leads to neutropenia. Then antithyroid drugs like thiouresil, anticonvulsant drugs like valproic and phenytoin, antipsychotic drugs, anti-cancer drugs, most of them do lead to neutropenia. And enteric fever, tuberculosis, and gram-negative bacterial septicemia. These are the other causes which lead to agranulocytosis. Of the viral diseases, HIV infection, hepatitis B infection, Epstein-Barr virus, and parvovirus B19. Then we also come across hemophagocytic syndrome or HLH, where we find that there is pancytopenia occurring. Malaria, Kala-Azar also lead to neutropenia. So this is a case of aplastic anemia, bone marrow biopsy. You can see the cellularity is about 10 to 15%, but consisting mainly of the lymphocytes. So what is missing? Myeloid cells are missing, erythroid cells are missing, megakaryocytes are missing. So this is a case of aplastic anemia, or it could be even Fanconi anemia. Then we may find aplastic anemia associated with PNH also. Now this needs to be differentiated from hypoplastic MDS. In hypoplastic MDS and in hypoplastic acute leukemia, what we find is marrow is something like aplastic anemia, mainly fat. The hemopoietic cells are markedly diminished. And in acute leukemia, you will find small clusters of blast cells. In hypoplastic MDS, the blast cells are few, but then you find abnormalities in the megakaryocytes as well as in the myeloid precursors. And this is the commonest cause of pancytopenia and neutropenia in our country, where we find in the bone marrow, it is the sheets of early megaloblasts, or what we call as megaloblastic anemia, where you find that it is a basophilic cytoplasm and sieve-like nuclear chromatin. And the changes you also come across in the myeloid series as well as in megakaryocytic series. Parvovirus B19 is well known that it causes pure red cell aplasia, especially, and what we find here, the diagnostic is giant proerythroblasts. Now, what are these giant proerythroblasts? You will find that the erythroid precursors are not present in the bone marrow. These are all myeloid cells. So what is present there are, you may come across an occasional giant proerythroblasts, which are large proerythroblasts having open chromatin, blue cytoplasm, and you find the cytoplasm make projections like dog's ears. So once you know this, it is there, then you have to treat only the parvovirus B19 infection. Then we go on to the lymphocyte morphology. Now, in the blood, we come across two types of lymphocytes. The small lymphocytes, which form the major bulk of them, and then we have larger cells. In larger cells, some of the larger lymphocytes have got granules in them, and we call them as large granular lymphocytes. Excuse me. So these are small lymphocytes and larger lymphocytes, or large granular lymphocytes. Now, whenever we are examining the lymphocytes in a peripheral smear, first of all, we look at the nuclear chromatin. It is a coarse clumping of the chromatin. Then we find in the small lymphocyte, there is a very thin rim of cytoplasm, which at times may not be visible. And when it is visible, it is a thin rim and blue basophily. If there is a lymphocytosis, as you can see in this particular case, no neutrophil, but the 8 or 10 lymphocytes you can see, all of them are small. And also there is a smudge cell. Now, smudge cells, lymphocytosis, mature type, it could be a case of CLL. But then we have certain criteria for diagnosis of CLL, like they should be more than 30% in the bone marrow. Those cells should be B cells. That means CD20, CD19, CD22 positive. Then these lymphocytes in CLL are also CD5 positive and CD23 positive. So that means B markers plus one T marker, that is CD5, along with CD23, then only we will label a case as CLL. So what we have to do is a differential count, look for the small lymphocytes, look for the larger lymphoid cells. And then the large white cells, they usually come to the, as I told you, at the tail of the smear. If I tell you to look for malarial parasite in a particular smear, you will find that in the exam, some students will pick up malarial parasite in 1 minute. Others may take even half an hour to pick up a parasite. What do that smart boy has done? You look at the tail of the smear. The malarial parasites are slightly heavier than the red cells. So as you make the smears, these go to the tail of the smear, the malarial parasite. So if you look at the tail of the smear, and you will find malarial parasite. So that is why it is easy for some students and difficult those who keep on looking in rest of the smear, so they are not able to find it easily. Then the smudge cells, I showed you smudge cells in cases of CLL is diagnostic. Now, what are reactive lymphocytes? Now, this is a common condition which we come across for about 10, 15 years. More so with the viral diseases coming up with COVID-19, we could see reactive lymphocytes. Dengue fever was the first one. There were earlier epidemics of dengue fever, thrombocytopenia in combination with reactive lymphocytes. Now, what are these reactive lymphocytes? See, the lymphocytes respond to the presence of the virus. With the cells, they try to become immunoblasts so that they can produce more of these lymphoid cells, which can mount a proper immune response to destroy the virus. So what we find here is that the reactive lymphocytes are of different sizes, number one, different shapes of the nucleus. And infectious mononucleosis is the example where we used to teach, or we still teach our undergraduates, that infectious mononucleosis, now it is caused by Epstein-Barr virus, and we find Downey type 1, Downey type 2, and 3 cells which are seen. Now, all of them are lymphocytes, but most of them are, or a majority of the cells are CD3 positive. That means those are T cells. If they're T cells, are they helper cells or not? No, they are not helper cells. Those are CD8 positive cells in cases of infectious mononucleosis. So the spectrum of morphology is tremendous in viral infections. Also, we've come across such lymphoid cells in autoimmune diseases following vaccination and drug hypersensitivity. Look at the morphology. See, you think of the shape and size, it is there. Large cells, but one thing is common in all of them, and that is the basophilia of the cytoplasm. The basophilia of the cytoplasm is seen in almost all cells. You will find immunoblast-like cell, you will find monocytoid cells, they are large cells, and then here you find the cytoplasm is granular. These are like large granular lymphocytes, monocytoid cell. Then you find here some cells which have got eccentric nucleus and more of basophilic cytoplasm, something like plasma cells. And then you find some of the cells are showing vacuolation in the cytoplasm. Some of them may show us granules like these one and large granular lymphocyte. So different shapes and sizes are seen, and we call them as either reactive lymphocytes as a reaction to the virus or to the autoimmune disease, or we call them as transformed lymphocytes. The transformation has occurred. Similarly, in drug reactions, radiations, Addison's disease, we come across these virus cells. See here, again, this is one case where you find that few platelets are seen, but the platelets are diminished. So this could be a case of dengue fever in which there are reactive lymphocytes. Along with reactive lymphocytes or transformed lymphocytes, there is thrombocytopenia. These are the plasmacytoid cells I was talking about, where you find the cytoplasm is basophilic, nuclear chromatin is coarse and clumped, something like we find in a plasma cells. And then you find monocytoid cells. Not only that, you come across even immunoblast-like cells in the peripheral blood. Now, this is a case of dengue fever, where you find it is the transformed lymphocyte, and there are no platelets in the peripheral smear. So the dengue fever will show us both. Now, large granular lymphocytes, as you can see here, there are granules in the cytoplasm, a sort of eccentric nucleus. Now, what about the LGL? The case below is LGL leukemia, or T-cell large granular lymphocytic leukemia. These cells are showing fine granules, very, very fine granules. Now, these are all large granular lymphocytes, and it is a T-LGL leukemia. Now, this is one neoplastic condition of T large cell granular lymphocytosis. But then we come across LGL cells increase in various viral fevers also. And we have to distinguish that whether we are dealing with the LGL leukemia or we are dealing with a case of reactive T-LGL response. Now here we find that this is a neoplastic response where almost all cells were T LGL type and CD3 positive, CD8 positive cells. Now, such cases of T-LGL are associated with neutropenia, sometimes with pancytopenia. So how do we distinguish them? If you don't have the markers for this, you can do flow cytometry. Flow cytometry will confirm the expression of CD3, CD4, CD8, CD7, and so on, and confirm the presence of large granular lymphocytic leukemia. In the peripheral blood, we also come across in 30 to 50% of the cases of lymphoma, there will be spillover. See, that means what has happened is the patient has got lymphoma in the cervical lymph nodes or axillary lymph nodes or intra-abdominal or thoracic lymph nodes, there is a lymphoma. Now that lymphoma goes to the bone marrow. So there is bone marrow involvement. It is something like a metastatic deposit of various malignancies. Similarly, the lymphoma cells go more so in non-Hodgkin's lymphomas. They go and settle in the bone marrow where they multiply, and as a result of it, they replace the normal hemopoietic elements. So those lymphoma cells, then they overflow the bone marrow and come into the peripheral blood. So about half the cases of non-Hodgkin's lymphomas will show us the presence of lymphoma cells. Now, what is the advantage of this thing is that we diagnose, patient comes, you examine the peripheral smear, and what is the peripheral smear showing? Peripheral smear is showing these lymphoma cells. It is only you who has to pick it up. Because unless you pick up these cells, you will not tell the clinician that there are atypical cells or these are lymphoma cells. See here, this is a case of CLL, where you find larger lymphocytes with a smudge cell. Now look at this cell. This cell has got round nucleus, but the cytoplasmic border is not like a lymphocyte. What is it showing? It is showing you hairy processes on the surface. Now this is a hairy cell leukemia. You all know that these cases are associated with pancytopenia, mild splenomegaly, and then you have that typical appearance in the fried egg appearance in the bone marrow. But their appearance is very classical even in the peripheral blood, and these cells are TRAP positive. What about this one? This is a splenic marginal zone lymphoma, where the cells are slightly larger, coarse chromatin, cytoplasm is moderate in amount, and the hairy processes may be formed in the direction in which you make the smears. Then here you find NK cells. Here you find the follicular lymphoma cells where you find a deep cleft is seen. And sometimes you find the cases of multiple myeloma. The patient has got a plasma cell neoplasm with multiple osteolytic lesions in the skull or in the pelvic bones. And you find the plasma cells come into the peripheral blood. There is rouleau formation also. So there is what we label it as plasma cell leukemia. Now, what we talked about were where the lymphoid cells were small. But sometimes you will come across large cell neoplastic lymphoid disorders like acute leukemia, ALL. It may be ALL L1, it may be ALL L2, where the cells are even larger, very, very prominent nucleolus is seen. But if you do myeloperoxidase, that is negative in these cells. Then there is L3, or the Burkitt lymphoma, in which the cytoplasm is basophilic, prominent nucleoli, and then there are cytoplasmic vacuoles, very typical. PLL or pro-lymphocytic leukemia, this is a very aggressive kind of chronic leukemia, where you find it as BPLL. There is also one TPLL, but nowadays, of course, the classifications are changing. So there is no longer any entity in the 2022 classification, but still it goes on. PLL, here you find there is a single eccentric nucleolus, very typical of PLL. Now, which is the commonest non-Hodgkin's lymphoma we come across is large cell lymphoma. And this is what it is. And then we have ATLL, in which you find polymorphic appearance of the white cells. See, the idea of showing you all these different kinds of cells is that as and when you come across a smear, you should think that it could be one of those, match with the book, or you take opinion of somebody. You can send the slides to me and we can confirm what kind of lymphoproliferative disorder it is. Now, since we have already done about the neutrophils, lymphoid cells, I'll just briefly go over some clinical aspect, and that is infection. See, we are all worried about infections, whether viral infection or bacterial infection. So what are the hematological manifestations of infection? Now, the first thing which happens is high band counts or the immature neutrophils, which I have shown you. See, the first project I did after becoming a pathologist, after doing MD, was that I got third-year student who were given a small project in summer vacation of about 15 days. So what I had given them was, one of the students was, in infantile diarrheas, to make a smear from the healed blood and to look for the band counts. The cases in which the band count was more than 10%, they were labeled as bacterial infection. And of course, cultures of the stool was done. And then the count bandemia gave us an idea whether it is a viral or not. If no band forms, they were taken as viral, probably due to rotavirus. Then we have immature granulocytes. So that means a peripheral smear, you find number one, that count is high, cell count is high, there are band forms, or the immature granulocytes, that is metamyelocytes, myelocytes are there. So that indicates that we are dealing with probably a bacterial infection. Now there is one term which we came across, NLR. What is NLR? Neutrophil lymphocyte ratio. Say in a particular person, we find 60% neutrophils. Lymphocytes are 30%. So what is the ratio? 60 divided by 32. So the ratio is 2. So NLR is 2. If NLR is raised, it is a marker for infection and inflammatory stress, which indicates severe illness. Okay, so that is one characteristic feature. Bandemia is one, immature granulocytes another, and the NLR. Now, more recently, what has come up is monocyte distribution width. Now that we come along with what is the meaning of monocyte distribution width is that once the infection occurs, the monocytes, they start swelling up and the vacuoles come into them. So what happens? Their size increases. So that means in the peripheral blood, we've come across monocytes of different sizes and different shapes. For shapes, we will have to do the smear making, stain it. As far as the size is concerned, we have the hematology analyzers. So they count the size, the volume of all the cells, of the white cells, neutrophils, lymphocytes, also of the monocytes. So monocyte distribution width is that if the monocytes are of different sizes, you will find the MDW is high. If all the monocytes are of the same size, which happens in a normal person, the MDW will be low. So monocyte distribution width is a hematological parameter which measures the different sizes. Now, how much should it be? MDW values of more than 20 is very significant. If you find that the MDW is more than 20, there is a high risk of developing sepsis within the first 12 hours of admission. So you can see the significance of MDW. That means if MDW is high, that child or that person is going to develop sepsis within the next 12 hours. So that means you start antibiotics right then. And if you start the antibiotics at that point of time, that means you are saving the life of the person or the child. So these are the various markers which have come up. Similarly, NLR. Now let's go to NLR. So this is the sepsis. So in sepsis, immature neutrophils can be seen, bandemia can be seen, and then NLR ratio, and then we have the MDW. So what are we looking at? What does the clinician look at? He gets the TLC, DLC done, but his eyes are on leukocytosis. Is the TLC more than 12,000? Is the patient developing leukopenia? Is the count less than 4,000? See, the clinician is worried. If leukopenia is there, leukocytosis is there, if bandemia is there more than 10%, or there is a microvascular thrombosis, that means the fragmented red cells may come into the peripheral blood. These are all alarming things. So we have to guide the clinician what we are dealing with and what we are looking at the smear or at the hematology report. Now, this NLR is the ratio of neutrophils to lymphocytes, and this is an indication of stress. Now, this is called stressometer. Now, what happened during COVID-19 infection? See, as patients are being confirmed that the patient has COVID-19 pneumonia, the X-ray chest or the CT showed that there is pneumonia. Now, which patients to admit? We know how the hospitals were full. There was no space in any of the hospitals for admission. So one of the criteria which was taken was NLR ratio. If the N by L ratio was high, now how much high? See, the normal is between 1 to 2. More than 3 is abnormal and less than 0.7 is abnormal. So the 6 to 9, suppose the ratio is 8. 6 to 9 ratio indicates a mild stress. Then what is moderate or severe stress? That is more than 10. So during that period, if the patient had NLR ratio of more than 10, that means the pneumonia is and the infection is causing a lot of stress in the body, and this is the patient who needs admission. So NLR ratio indicated. Now, why is it altering? See, NLR ratio will alter if either the neutrophils increase or the lymphocytes decrease. Why should lymphocytes decrease? Because some lymphocytes, they undergo lymphocyte apoptosis. So any dramatic elevation of NLR is compared to other forms of physical stress. And then the same thing happens in sepsis. Now, one of the indicators now is monocyte distribution width. But then NLR also indicates us, it gives us an idea that the sepsis is going to occur, because in sepsis, lymphocyte apoptosis occurs. So the lymphocytes decrease, the neutrophils remain the same or they increase slightly, as a result of which the NLR ratio also goes up. So the NLR ratio goes up, the monocyte distribution width goes up. So that indicates that we are dealing with a case which is likely to go into sepsis. And you all know that sepsis is a very, very serious condition. We have to give antibiotics to control the infection and the stress. So the NLR more than 10 indicates a severe systemic stress, as could be caused by a septic shock. Now, what about the monocytes? Now, I told you that monocytes distribution width is also an indicator of or a biomarker of sepsis. Now, when any infection occurs, whatever kind it may be, see, the first cells to respond are monocytes and neutrophils, what we call as innate immunity. They are the first ones which respond. Then we find that the lymphocytes come into play. Both B cells and T cells come into play. B cells form the antibodies. T cells, they multiply. They multiply. Cytotoxic cells will multiply. Helper cells will help. But sometimes, now this phase when these monocytes and neutrophils help is actually called the inflammatory phase. So what is happening in inflammatory phase? In inflammatory phase, there are inflammatory cytokines which are released. And if they're released in excess, So that means there is a cytokine storm. And what about this cytokine storm will do? This cytokine storm will lead to secretion of so many cytokines, which will either reduce the blood pressure, which will increase the pulse, which will cause organ failure and ultimately collapse because of the fall in BP. It will cause the coagulation abnormalities, the FTP or the fibrin degradation products will increase. So this is something which is happening also in HLH. We say that hemophagocytic syndrome or HLH is a very serious condition. We have to diagnose it immediately. Now, there are 9 criteria out of 9. We say at least 5 should be positive. So those patients are actually going into cytokine storm. So that means they're in the first phase of the disease where there is an inflammatory response. Then which is the second phase? Now, here also the monocytes are the cells respond. Second stage is of immunosuppression. Now, the body at times is not able to mount a response which is good enough for the bacteria or the virus to be destroyed. And the immunity is low. That is a phase of immunosuppression. So there is a sepsis-induced inflammation first, and then there is sepsis-induced inflammation plus immunosuppression. Now what happens is that because of the immunosuppression, you find the disease increases at once. And again, it may lead to the various complications of cytokine storm with high pulse, fall in BP, and DIC may occur, and these patients then die out. So how can we help the clinicians? We can help the clinicians by giving them the NL ratio is 1, monocyte distribution width. The moment you look at the cell counter and it is giving you an MDW of more than 20, you know that this patient is a very, very in serious condition and needs admission in a ICU. Now, there are so many articles which are coming up, but most of the cell counters which are there in majority of the labs in this country are still the old ones where MDW is not available. It is only the recent, since it is a recent thing, so you will find in very few cell counters MDW is coming, but I'm sure that in next 2-3 years, you will find that this parameter will be available at majority of the cell counters. Now, various studies where they've tried to find out that how much MDW is indicative of sepsis. There are some studies where they feel that MDW of more than 22 is very, very important and so on. Majority of them are taking as around about 20. Now, why 20? Now, this is one of the articles where you find that if MD values are below cutoff, what is the cutoff is 20, then the chances of severe infection are low. Suppose it is 18, suppose it is 15. See, that means the infection is there, but it is not severe enough to cause death of the person. So, on the other hand, if MDW is more than 20, as you can see here, you will find the cutoff increase, and then the probability or the chance of a serious condition is becoming higher and higher. Then we go on to, we have talked about the neutrophils, lymphocytes, briefly about monocytes. These are the various causes given in the book. I'm not going into the details. And these are the monocytes in COVID-19 infection. Now, one aspect I want to tell you about the monocytes is that there are 3 stages of monocytes: monocyte, promonocyte, monoblast. Now, this is a monoblast. Now, why I'm showing you monoblast is it is like any other blast. That is one. Chromatin is open, very, very open, lacy chromatin. Nucleoli, as you can see, are very, very prominent, basophilic cytoplasm. So it is like most of the blasts which we come across, but except for the nuclear chromatin and very, very prominent nucleoli. What about this cell? This cell is labeled as promonocyte. Now, what is promonocyte? Promonocyte is again basophilic cytoplasm, but this nucleus is not round to oval. It is lobated, it is folded, and it is a convoluted nuclear configuration with prominent nucleoli. I'll show you. See here. This is the monoblast. You can see here, similar what I showed you just now, 2 monoblasts. Now look at the promonocytes. Promonocytes have got a folded, convoluted, lobated nucleus, unlike a monoblast. These are immature monocytes, but then they don't have nucleoli. These are the monocytes where you find the vacuoles and all those things, but there are no nucleoli. So monocyte, no nucleoli. Immature monocyte, we usually count them along with the monocyte, so no nucleoli. Promonocyte, look at the promonocytes, nucleoli plus convoluted. And then, of course, the monoblast, which is showing you the nucleoli. Why are these promonocytes important? Why these are important is that whenever leukemia occurs of the monocytic series, we count promonocytes as monoblast. Suppose there is a case in which we find there are 10 promonocytes and 15 monoblasts. Now, as per the definition of our FAB, French American British classification, there should be more than 30%, but WHO then said more than 20%. So 15 monoblasts, it is not acute leukemia. But then if we add promonocytes, so it becomes 10 promonocytes, 15 of these, it becomes addition becomes 25. So that means the blast cells for all practical purposes are 25. They are more than 20%. So this is a case of acute leukemia. So therefore, it is very, very essential for us as pathologists to distinguish and tell the clinician that so many are promonocytes, so many are blasts. Add the two. Why add the two? Because promonocytes are blast equivalents. Why this term blast equivalent came? Now, this blast equivalent thing came from WHO. WHO said that these cells, though they are not blast cells, they are promonocytes, but they should be counted as blast cells, and therefore you will find promonocytes plus monoblasts will form more than 20%, and it becomes a case of acute leukemia. Of course, both of them are, this is a non-specific estrus stain, which is positive. Of course, these are the monoblasts, and convoluted nuclei, what you are seeing here, these are the promonocytes. Now, are there any other blast equivalent also? I think there is. Okay, maybe later on we'll come across again other blast equivalents. Now there are 3 more blast equivalents. Promyelocytes in cases of M3, AML M3. These are not blast promyelocytes, but still we take them as blasts. So promyelocytes are blast equivalents. Promonocytes are blast equivalents. Erythroblasts. Now, erythroblasts in M6 or acute erythroid leukemia, they are also blast equivalent, and the megakaryoblast in cases of M7 are also blast equivalents. So these are the blast equivalents you should be aware of, and that is how it started. Now, eosinophils, you all know the causes of eosinophils. I'm not going into the details except for the fact that in hypereosinophilic syndrome, this is the biopsy, bone marrow biopsy showing you sheets of eosinophils. Here, what you find in the smear is that the granules are both eosinophilic and basophilic. So you should have a good Giemsa stain done on the bone marrow to distinguish the red granules and the blue granules, and then diagnose as a case of hypereosinophilic syndrome. Now, the same thing may happen even in chronic eosinophilic leukemia, but in this particular case, majority of the granules are red in color. What is increased in chronic eosinophilic leukemia is the prominence of the blast cells. Now, these are the blast cells with prominent nucleoli. Then we go on to the basophils. Now, these are the basophils. The granules are covering the nucleus and difficult to see, except for the fact that sometimes, even in this one, you can see that pericellular, there is a sort of pinkish hue. Now that pinkish hue may be even more than this, and that is because of the fact that the histamine 5-HT is released, and that is what stains the pinkish hue around the basophils. But keep in mind that the basophils are CD117 negative, but the mast cells are CD117 and mast cell tryptase positive. Then, of course, the blast cells. Now, this is where I was trying to tell you blast equivalents. We talked about promonocytes. These are the promyelocytes in variant, M3 variant, though there is one OROD also. These are also blast equivalents. Then proerythroblasts in cases of M6 or erythroid leukemia. These are also blast equivalents. And then we have this M7. These are the biopsies from M7 because the aspirate is usually diluted because of the extensive fibrosis in these cases. And here you find that how do we confirm that these are all megakaryoblast is by doing CD41 or CD61 as we have done in this particular case. Now, platelet morphology, we may come across a hypogranular, granular platelets. They may be large, giant platelets, which are seen in Bernard-Solier syndrome, also seen in cases of acute ITP. We also come across them in dengue fever. Now, what happened? What is the significance in dengue fever? See, in dengue fever, there is thrombocytopenia. If we find there are a good number of such platelets which are large, now these are just released platelets. So that indicates that the regeneration of the platelets has started. So you may not give platelet transfusion to this particular patient. Just watch this patient for about 24 hours. You will find the number of platelets will shoot up like anything in next 24 hours. And therefore, the platelet transfusion can be avoided. Now, these are all giant platelets, very, very significant finding. And then you find spurious low count whenever there is a EDTA-induced aggregation. And this is platelet settlism. The platelets gather around the neutrophils and therefore the count appears to be low. Spurious high count, the cell counter counts these fragmented red cells and platelets because they are smaller. And then cryoglobulins. And then we go on to the thrombocytosis, where you find that the platelet count is high, more than 6 lakhs, and you find a case of essential thrombocythemia. Of course, you also come across high count in CML, myelofibrosis, polycythemia vera, and then it is a first response to any stress. So infection, inflammation, asplenia, post-surgery, you will find thrombocytosis occurs. Parasites, microfilaria, you have all seen. Vivax, multiple rings in falciparum, banana-shaped gametocytes. In the bone marrow, you will find that macrophages contain the malarial pigment, indicating an old malarial infection. This is a gametocyte of falciparum. Leukoerythroblastic picture is the term we say when we find immature red cells, that means the nucleated RBCs, or you find metamyelocytes and myelocytes. So leukoerythroblastic blood picture, and usually you find it along with some teardrop cells in the peripheral blood. So this could occur due to myelofibrosis, as you are seeing in this particular case, or metastatic deposit. You can see the metastatic deposit with desmoplasia. Or you may find even in osteopetrosis, where you find large number of these teardrop cells. These are the teardrop cells which you come across. I'm not going into the artifacts except for this one. Very often in rainy season all over the country, we find that the red cells are stained, but then you find these sort of vacuoles in the red cells. It is actually the water absorbed into the alcohol-based stain from the humid air, because the air is so humid with 50 to 100% humidity all over. So as a result of which you find that these vacuole type are seen. This is just an artifact. We should be aware of all this. Stain artifacts, of course, you all know. So the message is that evaluation of the PBF is a gold standard, not only for neoplastic or leukemias, but also for the non-neoplastic hematologic disorders. It guides us that what further tests need to be done. But we should be able to integrate the machine and morphologic data and present it on a platter to the clinician that this is the total picture comes with the machine and the cell counter and the morphologic data, what we are examining, so that he can institute the treatment accordingly. Thank you very much. And any questions, queries, comments, most welcome. And the next webinar will be on 10th of July. That will be on quality control in hematology, especially in coagulation. Time remains the same, 3 to 4 p.m. And again, Dr. Veena Kohli and Dr. Gaur are organizing it. Thank you very much. Any questions? Most welcome.
Thank you, sir. It was, I think, as the most complex thing as simplified as like probably we just, like, absolutely a layman's language, but I think highly educated. In fact, I personally, again, every time I hear from you, we talk about, and this time, the monocyte distribution width, that's something which is very, very important and gaining importance. I think this is something I would learning. Thank you so much, and thank you. There are a couple of questions on the inbox, I think, but we understand that the RBCs, WBCs, platelets, what they call them as, they are the, avengers of bloodstream. Without RBC, like there's no oxygen. Without WBC, any germ will overrun us. And without the platelets, even a paper will cut us and we'll bleed to death. But I think this is where, like somebody is defined as RBCs are the Iron Man, WBC is the Hulk, and platelets is the Captain America. These are the Avengers of the street. So in any case, let's come back to the questions.
You are too good at it, Dr. Gaur. I have to learn so many things from you. Yes.
Thank you so much, sir. I think they're like important questions now, sir. Like, one, this is the question which has come is, from Dr. I think we have, no doctor is not named here, but how common is the megaloblastic anemia in India, sir? That's one question. Anything on megaloblastic anemia incidents?
Recently, Indian College of Hematology has carried out the criteria for diagnosis of iron deficiency anemia and B12 folate deficiency anemia, and thousands of patients were studied. At one time, say 20 years earlier, we thought iron deficiency anemia is the commonest, as it is all over the world. But here we find that iron deficiency anemia is common, but so is B12 deficiency. See, we are all, majority of us are becoming vegetarians, and the diet does not contain adequate vitamin B12. And then we have certain food fads, and the result is that B12 deficiency is quite common. See, I would suggest that any patient or any person who has got anemia, smear must be examined, or cell counter, which will give us the MCV. And along with that, why I'm saying smear is that early megaloblastic anemia can be picked up on a hypersegmented neutrophil. More than 3 in the blood, it is B12 deficiency or folic acid deficiency. So you give a drug, you give a capsule of Bicosul or whatever, which contains good amount of B12 as well as folic acid. And this is one anemia which can be taken care of. And it is unlike iron preparation, which may cause constipation or diarrhea. B12 is it can be taken easily.
That's nice. I think that hopes that addresses the question. We have a question from Dr. Anil Vermani. He's saying, how good is the QBC technology to detect malaria parasite versus through peripheral smear? So what is probably asking for
See,
options?
whatever technology, whatever immunologic technology is taken, the gold standard taken is peripheral smear evaluation and the demonstration of a malarial parasite. I think QBC technology is good enough where we have large number of cases and the screening is to be done on a large number of cases in a short period of time. QBC is good enough.
In any case, they always say the human eye is better than everybody, any eye for that
Yes.
matter. So I think the next question we have from Dr. Partho is saying the NLR. It was extensively used for prediction of COVID complications and disease progression. What about other viral infections? Still like we can still use it, or what is the kind of guidance on that?
See, it is being used now for other viral infections also because they feel that NLR is an indicator of the degree of stress. The greater the stress, you will find that the NLR becomes high. In some conditions, it is the lymphocytes which are going apoptosis or the neutrophils are responding in a way by multiplying, resulting in the N going up. So N going up, L coming down, both ways you find that the NLR goes up. And therefore, in many viral infections, you will find that this thing is happening. NLR is becoming the thermometer for us to pick up that this patient does need admission or does need immediate treatment.
So I think the next move on to Dr. Ashima, sir. She has asked a question between difference between granules in eosinophilic leukemia and hypoeosinophilic syndrome. What is the difference between granules? Any difference?
Hypereosinophilic syndrome is not a leukemia. So that means it is not a clonal disorder. You will not find any cytogenetic or chromosomal abnormality. There will not be any molecular abnormality. Hypereosinophilic syndrome is probably a precursor, not to say precursor, but some cases which were diagnosed earlier as hypereosinophilic syndrome. Now you find that those are actually the cases of chronic eosinophilic leukemia, because at that point of time, the molecular studies or the chromosomal analysis was never carried out. But it is, of course, a very troublesome disease in which we find that more than 3 systems are involved, which happen to be blood, bone marrow, skin, liver, kidney. So these are various systems which are involved. And of course, the patient has cough and all those features. And the damage is caused by the eosinophilic infiltrate, not only in the lungs, but also in the myocardium. So the damage to the myocardium occurs in hypereosinophilic syndrome, maybe even more than what we find in chronic eosinophilic leukemia. It is a troublesome disease and need an exact diagnosis.
Hope Dr. Ashima that addresses the question. We have a next question from Dr. Bhagavati. This is, if monocyte count is 300, will it be possible for monocyte distribution width?
Again, if
the monocyte count is 300, will it be possible for MDWs?
Yes, actually, it does not depend upon the count. It is the variation in the size. See, because of the infection, the monocytes, they start swelling up. That is one. Second is you find that the vacuoles start appearing. As the vacuoles appear, again, their size increases. So you have some in which there are vacuoles, there are others in which there are no vacuoles. So there is a variation in size. Now that variation in size is picked up by the cell counter, and that the variation we call it as MDW. The higher the MDW, that means more variation. That means the more swollen up monocytes are there, or the reactive monocytes are there. And therefore that patient needs immediate attention and should be admitted immediately to the intensive care. That is what is suggested with MDW.
I think hope this addresses your question. We have from Dr. Rakesh. Sir, is there any role of high fluorescent leukocyte count parameter in dengue fever?
High
fluorescent leukocyte count parameter in dengue fever, HFLC, sir.
I'm not aware of this particular parameter. Maybe in some new cell counters, this parameter might have come. where they measure the fluorescence also. Yes.
So I think we
I'm
move
not
on to
aware of it.
move on to the next question from Dr. Reshma Agrawal, sir. Besides larger platelets, is there any other marker in PBS showing recovery?
Number. See, because the number is not high, good enough, so we look at the morphology. Because these are regenerating platelets, and the regenerating platelets can be easily made out on a Giemsa stained smear. So that is the best indicator, because the next stage is the number will be high. Today you find giant platelets, tomorrow you will find some giant platelets, some normal platelets, and the number will be more. So the number gradually goes up. So it is a precursor of a higher number.
Okay, I think we have another question from Dr. Reshma herself. Is the pseudo thrombocytopenia because of PTTA? In case, does heparin as an anticoagulant is equally good or better?
See, they say that, I'll give an example. We had a CRPF DIG who came to us from Madhya Pradesh, says that my count is low, platelet count is low. We did the platelet count. It was 10,000 only. Then next day, we again called him, collected the blood in heparin, put it in the cell counter. His count was 1,70,000. So heparin, citrate, if you take the blood in that, you will find that since there is no EDTA in that, no antibodies, so the counts will be normal. But we are not aware of this thing. But this patient had come, and being an intelligent, he knew that he's having thrombocytopenia.
Thank you. I think we have another question from somebody name is not here. He says, like, how long the blood transfusion history is significant as far as peripheral smear is concerned?
How long is the
Blood transfusion history, sir, is significant as well as peripheral smear is concerned.
again, question is not clear.
Maybe try to ask is like somebody has been given a blood transfusion yesterday. So like the effect of transfusion on smear examinations, how long will that last?
See, if we give a transfusion now and examine the peripheral smear after 2 to 4 hours, the only thing which can be manifested is platelets. Again, in platelets, it all depends how many platelets transfusions have been given, or how much quantity has been given. Because the other manifestations will not be very, very clear. We can't make out on just a peripheral smear examination. No, only the platelets may give us some idea. Unless sometimes what happens is that the matching is not there of various transfusions, the blood samples given. So then there is a hemolysis occurring. So sometimes we come across that there is spherocytosis, and that spherocytosis is not because the patient is suffering with hereditary spherocytosis, but has developed autoimmune hemolytic anemia. Again, it takes time to develop. So the immediate thing could be some idea about the change in the platelet number.
I think probably we just have 2 more questions, and after that, I think we'll probably pull it off. The one important question is like when the Leishman stain is a cornerstone for a good PBS. Again, is by I think Dr. Roy. And so, what are the common precautions we take to get in the lab for how to have a good Leishman staining? So, what are the pitfalls and very common things which advice you can give to get a good stain?
See, what is the precaution? First thing is fixation is very important. And in Leishman stain, the fixation is there in the stain itself. Methanol is there. See, the only thing is once we pour the stain on the slide, then the slide should not be picked up. So what we should do, how should we wash the smear? Take a drip bottle, plastic bottle with a long nozzle, pour the buffer water from one corner, that will drain the stain away. Otherwise, as you pick up the slide, remove the stain, all the stain particles will stick to the slide, and you will find that it is a dirty staining. So that has to be avoided. That is only by washing by that drip bottle, and it gives beautiful results Not even a single stain particle will be seen anywhere. Can be tried even today itself.
Thank you, sir. And I think last and most important thing what you talked about, and that was I was also wondering, you talked about stress meters. And that's a question which has come from the audience. Is it nowadays the stress has become so much common against all age groups. How does it affect a normal person's NLR? Sir? Does it affect?
Uh, at least I haven't come across any study, but yes, it is worth it. And I wish I had some postgraduate now with me so that we could carry out this study and assess the degree of stress as related to the cell counts. Let's see if one of you can do it, and then we'll know the results.
That's a good idea. So I think we can start the questionnaire at our lab walk-in center. Like anybody having stress, at least quietly put a click out there, and we may do some
Yes.
study on that. In any case,
Sure.
thank you so much, sir. I think it was a great for you and for all of us. We had a great learning. I have again, I'll say before I close down, it's my habit to like travel to different part of the world. Like sometime I travel to the past, and sometime travel to the future. And so this is where I probably have thought of like, okay, when we, and in fact, there was a question somebody asked about human eye. From that angle, I just thought, okay, if I was like, the world of Shakespeare, who was known for the words, master of words and expression, and if he was asked to examine a peripheral blood smear in his words, how would he report? So probably the answer was like, upon a canvas of glass doth lie the vital essence of life itself, spreading thin and observed through the lens most wondrous. Here in microcosm, I see the scarlet voyagers, red blood cells, coursing forth with a duty most sacred to bear the breath of life to all corners of the body. Amidst the dwell the valiant white blood cells, the watchful sentinels, whose numbers swell in shapes, shift in times of strife, ever ready to confront the foe of disease. And lo, the platelets, tiny guardians, gather in clusters, poised to stanch the flow of blood and mend the vessels rent by injury. Thus, in this spectacle of blood's passage, do I witness the eternal struggle and triumph of life over adversity. Probably that's a report of Shakespeare, probably will give us wonderful, but no word. But then, like, I like the report, I like the words, but I felt my lab is becoming like a ballet hall, and like how much help will go to the clinician. Probably, but in any case, that's a great expression. Now, when I travel to the future, probably I had probably asked Dr. Artificial Intelligence, how will you examine a blood report? How will AI give the report? And AI said very this thing. It says, upon examination of the PBS, RPCs appear numerous and uniform, efficiently fulfilling the role of oxygen transport. White blood cells, varied in number and type, indicate the state of immune response with no apparent abnormality suggesting infection or inflammation. Platelets, present in adequate numbers, reflect proper clotting function, ensuring vascular integrity. Overall, this smear shows a balanced and healthy hematological profile, indicative of normal physiological process. A great report in any case, but I found it a little dry. It's fully automated. There is no life in it, actually. And so we just couldn't align the real kind of a report with the life. So then I went back to hematopathologist, who's current person. When was asked, why don't you report? Let me see, how does it report? Then the report was, upon examination of a PBS, the RPGs appear normocytic normochromic with no significant anisocytosis or poikilocytosis. WBC's differential reveals the balanced distribution of neutrophils, lymphocytes, monocytes, eosinophil basophils with no atypical forms of abnormal inclusion, suggesting a stable immune status. Platelet count is within normal range, with platelets appearing adequate in morphology and number, indicating effective hemostatic function. Overall, the smear presents hematologically normal profile, no hematoparasite, with no evidence of metabolic pathology. Now, this is called real info, which can be a big help for deciding treatment and the clinical outcome. I think this is some of the good hematopathologists can come. But when it comes to you, sir, I think I'll probably say your words are as good as Shakespeare. Your intelligence is as good as AI. And of course, you have the combination right expert. Thank you so much for a wonderful being session and being there.
Thank you so much.
I think we all are grateful to you, sir, for all this. In the end, I think before I sum up, we'll just say that the next session, of course, is on evolution in hematopathology. That's ensuring quality and precision practice, especially reference to coagulation, which is around 10th of July. All of us having a summer break. Be safe, take care, have a good holiday in June, and probably will come back. Meanwhile, if anybody has any query, there are email or numbers out there. I am Dr. Gaur, like drgaur61@gmail.com. I think right back, we will definitely be happy to address all questions. Thank you, sir, again. Thank you, Veena ji.
Thank you
And
so
thank
much.
you, everybody. Back to
Okay.
Veena
Thank
ji.
you, everyone. Thank you, Dr. Gaur. And thank you, Dr. Veena. Thanks a lot.
Thank you very much, sir.
Thank
Thank you.